Morning, everyone. Some of you look familiar. As Danielle said, I work here. We see patients who are here right in their own rooms or in their apartments, wherever they may be. And I tend to be here once a week, so you can stop by weekdays, and we try to base ourselves in that office just for extra questions, be a familiar face, any of that. So always feel free to stop by if you're going by to say hello if you have any questions. So I was asked to come today. Some of you have heard some of this spiel before, but to talk about our hospice program. And the reason why we want to talk about it now and invite everybody to come is so that people know that it is a benefit. It is a benefit that everybody has through Medicare. And the services I'm going to talk about today are covered at 100% with no copays, out-of-pocket expenses. The goal of hospice is to provide comfort to people when they have a limited prognosis and either treatment is no longer an option or the treatment options that are available are not desired. Our focus is on comfort and quality of life. So we like to let people know hopefully well before you ever need hospice so that you know that it exists. So if and when the time comes for yourself or a loved one is trying to make decisions about where they want their medical care to go, what kind of quality and quantity they want in their life, that you know that this is part of the option that you can consider. The other thing I like to let people know right away is that this conversation only starts today, it doesn't stop. So as I said, really you can stop by our office anytime, you can call our office and have a visit set up to talk individually, free of charge. We don't get charged for the visit for us to talk about where you are medically, what options you're being provided, what the prognosis looks like, and where you want to go. What we want and where the focus of hospice is on your personal wishes and goals, not ours. So the hospice benefit, how many of you have either had a loved one or a friend, somebody familiar with hospice? Okay, a fair number of you. So hospice has been around, I think, for about 40 years now. We might be getting a little bit older, which is very exciting. It started as grassroots movement, and it is now a standard Medicare benefit. And I just feel like we need to shout out to Medicare because we don't always get to say nice things about health insurance. But to understand that there is quality and benefit to quality, focus on comfort and quality at end of life with a comprehensive team to serve you right where you live is remarkable. It was the first of its kind. There are very few programs that apply to people in other areas in healthcare. So I always feel like it's really good to know that it exists. So the benefit, as I said, provides care in your home. And what we do is we bring services in. The easiest way I describe it is hospice tends to replace further visits to the hospital and the emergency room and can replace just about all of your medical visits. The goal is that you have nurses come to you rather than you having to spend energy going out to continue to attend physician and other appointments outside of your home, so that you can conserve that energy for things that are much more enjoyable, such as knitting. Typically, our nurses will visit several times a week, and they are experts in comfort and end-of-life care. So they're taking a look at what's going on symptom-wise. We care a little less about where that pain, for example, originated from or why you have it, so much as how do we help you treat it. So how do we help you get pain under control so that you can focus on the things that you like to do? We also have home health aides that are available to help with showers a couple times a week. For anybody who's living on campus, right here in this building, we're able to offer those home health aide visits 5 times a week. And for people out in the community, they typically get a visit once or twice a week if they're interested. There's social workers like myself. We are available for resources and support. And that's for our patients, but also for family members. One of the really special things, again, about hospice and where I think they got it right was that it is understood that when somebody is at the point of making a decision on focusing on comfort measures,
it's not only just affecting the patient, but also the family and loved ones. So the service offers those benefits. So sometimes I'm meeting with somebody as a direct patient. Often I'm meeting with family members, making sure that they have the supports that they need, that they have the resources they need to make sure if if you're a loved one in providing care, that you know what your other resources are if you need to bring in additional caregivers into the home or navigate legal things. So that's part of the benefit. We also have another counselor who offers non-denominational spiritual counseling. She also offers music enrichment. So she has a variety of things that she can offer. Again, those are offered for comfort and quality of life. And we have volunteers that are available. And I'll put in a plug. As you're listening today, if you are not, but you are ever interested, you are welcome to also apply to be a volunteer with us. Our volunteers offer a couple of different services. We have some people that serve just on campus here. We certainly have people that serve in the community, but can offer companionship phone calls or in-person visits with somebody who's on hospice. We also, sometimes they'll provide a little respite. So sometimes our volunteers will go in and sit with somebody because they can't be left alone. But it allows the caregiver to run errands, get a dream, take a nap, take a shower uninterrupted, any of those things to be helpful. Volunteers have a number of other things they can do with our agency, so if you ever had interest, please let us know. I'm happy to connect you with a volunteer coordinator to go over any of the other things. But as a patient, it can really be lovely. Typically, it's a weekly visit, so it's a wonderful way to get to know another person and just have a friendly face and some good companionship. Sometimes people play games, sometimes they're just listening quietly to music or TV, a variety of things. In addition to those, we have a 24-hour, 7-day-a-week helpline, and that's where a nurse is available from our agency as a live voice anytime it's needed. The idea being, if somebody's coming on hospice, we're expecting things are going to be changing. Symptoms are going to be changing. Unfortunately, disease is going to progress. But with that in mind, again, to keep people having to go back and forth to the emergency room or wait for hours and hours or days to be able to touch base with their doctor to change a prescription, hospice is available essentially in the moment to be able to answer a call. From there, our nurses can help expedite or changes in recommendations for care treatment and for expediting those orders, so things can be changed as soon as possible. So you can stay in the comfort of your own home and things can get changed on your behalf. Here, we also work with the facility staff. So the facility staff, for example, sometimes calls and says, hey, our pain medication plan isn't working, and we're able to help them right over the phone and get that moving. The other thing that's nice with that on-call service is if we can't help over the phone, then we'll send a nurse out. We help over the phone intentionally because it's the fastest way to get everything changed. But if we can't do that, then we'll send a nurse out, even if it's 3 a.m. on a Saturday. Again, the goal is keeping you where you are or your loved one where they are to be comfortable. So we'll come to you. In addition, medications and medical equipment that are focused on comfort and end-of-life care that are ordered are also covered by the benefit. And our team lets people know about all of that as well. What are the limitations of the benefit? The benefit does not cover room and board. So for anybody who's living here on campus, anytime in the future, certainly know that your room and board would remain as it's arranged now. But we come in and add to the services here. So the good news is nothing changes here. Whether you're wherever you're living now, whatever your services are, they remain in place. We'll add to them. And again, as I said earlier, we coordinate with the team here. So we all work together. And in that, you are still the decision maker for yourself or your loved one. That decision making doesn't change. So hospice makes recommendations. We do have a physician who's a hospice specialist. We have a pharmacist who's a hospice specialist. We all work together as a team to make recommendations and can explain the why and the rationale for why we're recommending something. We make those recommendations to the team here. They're the ones who administer medications, change their care plan, all of that. But you, the patient or the caregiver, are making the decisions. So it's really up to you about what sounds right for your life or your loved one's life. All right, that was tons of information. I get it. What questions? Yes.
There used to be a limited time designated that you have to fill to qualify for hospice. That's changed, hasn't it?
So yes and no. So the question was, is there a limited time that you have a prognosis in order to be able to qualify for hospice? So Medicare still has a guideline that 2 physicians have to determine that an individual has 6 months or less as a prognosis of their life if the disease were to maintain a typical expected course. So that is a qualifier, and that remains the same. That is sort of, from a hospice perspective, sort of a box to be checked, and then we move on. So once somebody's on hospice, an individual can receive the service as long as they need it, so long as they continue to demonstrate that there is some level of decline that's meeting that Medicare standard. So there's much more into it. There's periodic recertifications. It's the hospice team's responsibility to be demonstrating that we are seeing evidence that somebody is continuing to decline and that somebody remains appropriate for hospice. There are certainly situations, they are not often, but they happen enough, that somebody graduates from hospice. One of the easiest examples is sometimes we have people come on with an infection that they're not getting over, and it looks like they may be nearing the end of their life. And despite best medical knowledge, they recover after not recovering for a while. So sometimes we say people stabilize and they can be discharged. And if that were to ever happen, they are still eligible for hospice in the future when they meet criteria again. The other thing just to tack on with that is that this is an elected voluntary benefit, so people also have the right to revoke it. So again, often we have a discussion or two, sometimes more, of readiness for hospice. Medicare wants to know that we're all sort of on the same page of focusing on comfort measures, but realistically, we also live our lives, and suddenly, for example, somebody has the option of cancer treatment and has decided, you know what, I don't want to do this again, and they elect hospice. And then they find out that the granddaughter in Arizona is about to get married, and they really want to make it out to that. If you want to start treatment again, you can revoke the benefit of hospice, go back to treatment, live your life in your best way, and know that hospice is available again in the future. Again, it's meeting that criteria. And you have a whole team. And one of the things I love about hospice is you have a whole team, so you're not in that decision-making category on your own. We can help together with you talk about the pros and cons. If you start chemo, what are some of the things that we can talk through? Will it make a difference in your prognosis and your quality of life? Hospice team members are not here to make a decision for you or to steer you in any one direction. We're here to make sure that you have all the information you can have to make the best choice for yourself. Yes?
Is there a limit on how much time or how many days you can be in hospice?
So the question was, is there a limit on how many days or the time on hospice? So the answer is no. So we have people that are on for weeks, months, and we have people that are sometimes on for years. The key to that hospice service continuing is that you continue to meet that medical criteria that Medicare has set out. And it's our agency's responsibility to be able to continue to demonstrate that. If we ever thought that wasn't the case, then we would be letting you know that we think, hey, maybe things are stabilizing and you may not continue to meet that medical criteria. But otherwise, there is no end date, which is a pretty special thing. The other thing I want to add into that is, because you also mentioned days, is the hospice philosophy and what evidence, they've done a lot of research, is the sooner people get on hospice, the earlier in their prognosis and readiness for comfort measures, the better the outcomes. People tend to feel better. They tend to be taking less medication. They tend to have improved quality of life. And believe it or not, they actually end up living longer, a little longer. And the reason for that is once people realize and get the benefit of hospice and getting symptoms managed, sometimes that includes getting off of medications that were more focused on treatment or are treating things that were longer term concerns, that we discontinue those medications if you feel ready to do that. People have fewer side effects. They feel like they have more support. They're not spending all of their energy coming and going from medical appointments that they're questioning the usefulness of, and instead they're focusing on the things that they want to do. So the biggest critique that people tend to say is they wish they started hospice sooner. And that's one more reason why we start this conversation now, is to tuck this into the back of everybody's minds to know that it's available if and when that time comes. Yes.
My experience with hospice has been a number of years ago. And my sister-in-law was patient at the hospice care center in Itapur. And is that still available? Is that part of the plan?
Great question. So the question was, it was from a personal experience, but that a loved one was in an inpatient hospice facility. So there are still inpatient hospice facilities, but since many loved ones have been in there, the rules in Medicare have changed for the funding of that. Inpatient hospice generally is really set up for when people are not able to get their symptom managed at home and they need sort of a hospital level of care. With our hospice, because of those changes, because it used to be utilized differently, Medicare has changed the rules. So because of that, we no longer have an inpatient hospice connected with our hospice. What we do instead, if we can, there are a couple levels. So if somebody has a symptom that we're having difficulty managing with those every couple of days visits, we increase to daily visits. If that's not, and phone calls, of course. If that's not working, then we can increase. They even have something that we can sometimes offer called continuous care, which is we have somebody come in and we're increasing medication maybe every 15 minutes, every half hour to try to get things under control right at home. If that's not appropriate or successful, then we also have general inpatient, where we would have somebody go under hospice to the hospital specifically for that pain management, with the idea that, again, the symptoms being looked at every 15 minutes by a nurse. So there are a couple different levels. Inpatient hospice sort of parallels that hospital level of care. So absolutely, there are circumstances where somebody might be leaving a hospital and be going to an inpatient hospice still. Inpatient hospice now, however, is no longer considered a long-term place. It's considered temporary, where people are told to consider it about, I'm going to say about 3 days, with the plan that you will discharge there and go somewhere else afterwards. So it would either be coming back to your home or moving to a nursing home. So it's different than how it used to be. So with that, there are a couple left. I'm going to say in the community, there are like two or three, sort of between Slippery Rock, higher north, further north. Really, there's sort of one between here and Pittsburgh at this point. So it's not really considered a primary plan of care, and it's also not a guarantee. That is not something you can say, okay, I feel ready for this. It's a completely different admission process now. So the hospice team instead, you're not alone. Others had wonderful experiences in inpatient hospice. The way the rules run now, instead what we do is we talk about what's that level of care that we're predicting that you would have wanted to use that, and instead talk about how you can do that at home or utilizing, for example, what you could utilize on campus.
The benefit is that you don't have to travel to be with your loved one. but they're able to stay at home.
Correct. Yeah. It was commented the benefit is that you don't have to travel to be with your loved one if they're able to stay at home. And people are more comfortable at home. I mean, that's part of, part of why everything is sort of pushed back to what can we do. Most people say they want to be in their homes when they're at the end of life. And so because of that, we're able to do whatever we can to teach you and the team here how to be able to support them very safely and comfortably. Yes.
Oh. I don't know if you remember the situation. Okay. Their breathing therapy. Hospice did not pay for the rest of that, the kneeler. So we tried the hose and machine mastic as a wetty. So I talked to the nurse this morning, and there's another comparable. There's albuterol, which is like that, and you're done. That's not all you need. So I'm considering getting out of hospice and going back to the insurance. That's possible, right?
Yes. So the question is from a personal example that there's a medication that is not covered under the hospice benefit. And sort of the question is if you want to stay with that medication, that what's being offered as we call them conversion medications. So what's offered as a conversion is not desired by the family. You do have the right to revoke. So with hospice, hospice, like any insurance, has a formulary. So there are medications that are covered and medications that are not covered. The hospice team determines what medications hospice will pay for based on the individual and the plan of care. So certainly, as unfortunately sometimes people experience that there is not an exact equivalent. So sometimes it's switching from a brand name to a generic. Many people have had this experience already. Sometimes it's called a conversion, which is there was one medication that's used before hospice, and instead we have a different medication, but it treats the same symptom as that difference, but to cover the symptom. And you're right. Sometimes, often, people find that that's helpful and sufficient. That's not always the case. And that's where I like to remind people that this is your plan of care. This is yourself or your loved one. You're deciding what makes the most sense. And I also let people know what may not make sense right now might look different in 6 weeks or 6 months or 6 years. So to know that it doesn't necessarily have to be an end-all be-all, but that individual piece of being able to have all the information you need to know whether or not is this the right time and is this the way that I want to go. There's always an option of paying for any medication, continued medical care that isn't covered by hospice, seeing a specialist, for example, like continuing to go to oncology. You always have the right to pay for that out of pocket. Usually, things are cost prohibitive, and we completely understand that as individuals, so we want to make sure that everybody's as informed as possible so they can make their best decisions. If anybody does decide to revoke the benefit, they revoke the benefit, they go on to the regular insurance, so whenever that coverage was initially goes back into place. And then at any point in the future, then they're able to come back on if they want to review the benefit and come back on in the future.
What's the difference between hospice and palliative care?
Wonderful question. So the question was, what's the difference between hospice and palliative care? Palliative care is a program that's offered. It's really, it utilizes the home health benefit of Medicare or your insurance, not the hospice benefit. It is designed to be a short-term, home-based service for people who cannot leave their homes, to provide typically teaching, short-term nursing or physical therapy assistance. Sometimes there are other therapies. But the idea is that it's sort of I'm almost going to say short-term at-home rehab or nursing care. So I've said it about 6 times, and I mean it substantially. The biggest difference is that it's a short-term benefit. So typically, the insurances treat it very differently. They have a set number of visits that are allowed. It does not have that same rolling idea that you can be on it for as long as needed. This is a time-limited. Insurance typically decides how many visits are appropriate for a certain diagnosis and need. And service typically will end after a set number of visits. Respectfully, sort of whether you as an individual feel ready for that or not. Our team always works best to figure out the right balance, but it is an insurance-driven time frame, not a patient-driven time frame, where hospice, once you meet the criteria, the time frame is yours.
So in order to get that particular medication, we cannot be on cost.
I am happy to talk to you.
Like paperwork.
Yep. So I'm happy to talk to you afterwards about your individual situation, but it's to share. She was asking about getting medication coverage, and again, what I would say is we look at every case individually. We try to make sure people are as informed as they can be, so that they can make the best choice. And we realize, that often, just with all of the things that are going on, the best choice is the best choice in the circumstances with these options. But we want to make sure that you as an individual, you as a family, know what your options are so you can make the thing that feels right. Any other questions? Yes.
What is the difference between the palliative care and palliative care special needs?
So the question is, what's the difference between palliative care and palliative care special management? I'm going to say it's depending on what office it's from. So we refer to palliative care through the VNA as a home health benefit where we come to you. It is home health, so short term, but the focus is that we're trying to weave comfort, looking at comfort and quality of life while you're still treating. So we're sort of have this overlap. I'm going to say gently, think of it as it could almost be considered a bridge, although many people don't use it as a bridge. But the idea of, there's sort of, let's say there's home health when you're 50 because you broke your leg and you need PT at home for a few weeks before you go back to work. Then there's palliative where maybe you broke your leg, but you also have a cancer diagnosis and you're having a lot of symptoms. We're able to come in and offer a bridge to look at some of the comfort measures and quality of life questions that are going to be different than if you were 50. With the idea that they'll either improve and go back to treatment, or maybe that's a time that you're making a different decision about whether or not you're feeling ready and whether you're qualifying for hospice. A palliative specialty, there are palliative departments and I'm going to say sort of clinics that are also wonderful. They tend to, they would then be case by case whether they do home visits. Often you're traveling in to see them. Sometimes they're tied in with where you might be getting other treatment. So same philosophy, different providers, and the other biggest part being, are they coming to you or are you going to them?
Sam, I have a question. If I'm deciding to go with hospice and I'd really like my primary care doctor, do I have to give her up and go with your doctor, or can I keep my own?
So the question was, if you are thinking about hospice, but you really like your primary care provider, do you have to give your primary caregiver up and take the hospice doctor, or can you keep him or her? So the answer is you actually get to keep your primary care provider. You get to decide. Our hospice physician remains involved with every patient anyway, offering recommendations and consultation to the team, but we work with, it's actually, not only are you able to maintain your relationship with your primary care provider, if you would like to continue to go and see him or her, you may. That is covered under the benefit. Running extra blood tests, other things, is slightly different, but we just talk about that case to case. The other thing, sometimes people say the opposite, which is you love your primary provider, but respectfully don't want to have to leave to go see them anymore, or you really want to limit those visits. That's also okay. So typically, because you have such regular nursing contact, those primary care providers will take all of those updates from our nurses as enough information, but they remain involved throughout your care.
Quiet group. Any other questions?
Well, I could put in a comment. I have bouted care at home, so did my husband. But after I had my knee replaced, I had therapy at home until I was able to leave. Will make it a couple weeks or so. And my husband had an incision after surgery that just wouldn't heal. And the nurse was there every day over the summer till she finally healed it up. And most times, the care was absolutely wonderful.
Wonderful to hear. Yeah. Yes.
If you're in a hospice at home, can you leave your house? Can you, go up somewhere or fine?
You just asked my absolute favorite question. So the question was, if you're on hospice, can you leave your house or you have to stay at home? So the answer is, not only can you leave your house, you can go anywhere. It's really, really exciting to me. So hospice, again, has a different rule than home health. So as I said, that home health, some people have had experience with home health. Even that palliative benefit, you have to be considered homebound. So you're not allowed to do other things rather than really essential visits, which is very appropriate for many people. Hospice doesn't have that rule. So I actually tell people, you're free to roam about the country. And I have helped people make all sorts of wonderful trips. So everything's individualized. There are ways, sometimes what we do is set up travel contracts with another hospice. So if somebody's going somewhere for an extended period of time, another hospice is available to come in an emergency and we stay on board. Sometimes we end up ending the hospice benefit because they're going, I've had people go overseas. They were planning on a trip, same sort of story I used before. Suddenly there's a granddaughter that's getting married, they want to be there, they're able to revoke the benefit, go to Europe, go do their traveling, and then come back. So for many people, the day-to-day is much simpler than that, but you're allowed to go out of the house all day, every day, go visit family, go to camps. We have all sorts of things. So there are no rules about that. Really what we do is we tell people, let us know if you're going to be away anywhere overnight, because if there's an emergency, we don't want to be trying to figure that out at 3 a.m. when we've driven to the wrong place. But we work on that case by case. And as you may have heard, I get really excited about those things. I approach, and our team approaches not with well, you can't, but how do we make this possible? There are sometimes the risks, but you get to make your own informed choices. And with the woman I knew who traveled to Europe, for example, while we knew that would mean that she would revoke the benefit, we were able to talk extensively about what medications would be needed, whether oxygen would be needed, making sure the family could secure their own wheelchair and other medical equipment so that everything was in place before they went.
When she got home,
Yep.
was she back on hospice there?
Great question. So the question was, and when she came back, could she get back on hospice? So she had to re-enroll, which just meant she needed to what we said is call us or your doctor when you get back home, and we just needed a new order, and we're able to just set a readmission, and she came back onto service. Yeah.
Sounds like it happens pretty quick.
She didn't have to wait a week or two to get back home.
I tell people it can be a couple days. We do, and we understand all situations are different. Sometimes there can be something that feels like it's much more pressing and timeliness is really important. We do try to move as fast as we can in those circumstances. So sometimes it can be as fast as a few hours. I tell people expect it to be a couple of days just so you're not waiting at the door. We do our best work when we're not rushing because it means we can put everything into place so that hopefully we prevent there from being that acute need in the future. But yes, it would be extremely rare if they would ever extend to a week unless that were based on an individual schedule. The other thing we do is we coordinate with discharges from the hospital or moves from one area of the facility. So sometimes if you're moving from an independent apartment and you or your loved one has to move into Tionesta or one of the suites here, we can coordinate so that we can put needed medical equipment in place prior to your move. So it's one less thing that's making things uncomfortable. So we try to do whatever we can to make all of those transitions as seamless as possible. Great question. You can tell it's my favorite. I should actually, as you're saying that, I was like, you know what, I should put a map up of the places I've helped people get on hospice. It's been pretty exciting. Yeah. Yes.
I think at the beginning when you introduced this whole session, you said something about there are things that are available through hospice that don't seem to be appropriate for a given situation. What are examples of what you're talking about?
So the question was what I may have been talking about when I said there are things that may not be appropriate for the situation that are available through hospice. If I'm thinking about it, what I may have said was that sometimes people are not ready to focus on comfort measures only. Sometimes, and this may be short-term in somebody's life, it may be how they want to live their whole life and how they picture their own end of life and death. Some people want to continue to have CPR and be resuscitated and try any treatment, anything that's available through end of life and have their life end in a hospital trying to survive. Hospice doesn't have a judgment on that. It's just not what the benefit provides. So it focuses specifically if you are still interested in treatment, if you are still interested in going and trying, whether it's 1 or 7 more options at the oncologist, by all means, do what feels right to you. Hospice is available when those are no longer an option. And so there is no treatment option. Chemo is not going to be helpful. The oncologists are going to stop administering it. Or surgery might be helpful, but unfortunately your loved one is no longer a surgical candidate because their heart is so weak, it's not going to make it through the surgery and they're not going to try. Those are circumstances that maybe that's the time where you would want to focus on comfort measures. The other thing is I mentioned CPR. You do not have to be a DNR to come onto hospice. So for some people who many things are happening, we refer to it as, we say nature will take its course if and when that time comes. And being able to then talk about any comfort measures that we can offer so that is as peaceful and pain and symptom-free as possible. All right, everybody's stirring, so I'm going to take that as a cue that we finished this. But again, feel free to ask questions anytime. Stop out in the hall. You guys all got a brochure. You can call that number anytime and just say you're looking for more information or whatever, or we can go from there.
I'm always available to have those discussions. We also have a nurse practitioner that also will talk with people. She's able to look through, with your permission, of course, look through your medical record and talk in really specific detail about what's going on medically. So for many people, that can be really helpful for themselves or their loved ones as well. All right, thank you very much.
Thank you, everyone.